Thank you, Dr. Ganji. That's an excellent talk. Can't wait for the roundtable. If anyone has any questions, please submit them so we can get a good roundtable discussion going a little bit later. So the next talk, the title almost reads like a Reddit thread. This is from Dr. Martin Auerbach, who's nuclear medicine at UCLA. He's very committed to this conference. We thank him for coming every year. So here it goes. Here's the Reddit. Alpha or beta, which is best for me? But this is a talk about peptide receptor radiotherapy. Let's do a fun fact. Dr. Auerbach has an Instagram account collecting spots on, really? Spots on hospital stairs. Like dirt spots? Clean? I'm gonna go right now. So yeah, check out his Instagram about spots. Spots on hospital stairs. So let's please give a warm round of welcome for Dr. Auerbach.
Thank you, Andy. Don't tell UCLA about the spots, please, otherwise I might get into trouble. Always a pleasure to be here. You are the reason we do our work, and our work is satisfying because we can help you. And the feedback from you as patients is always helpful and informative, and really helps us give you the best possible care. Special shout out to Sweden. Heja Sverige. Jag är gift med en svensk fru, so my wife is Swedish, so I speak a little bit of Swedish. So tack att ni har kommit här. All right, so I was asked to talk a little bit about alpha therapy in the context of PRRT. So I will do that now. So first I'll talk a little bit about what is PRRT. Most of you are familiar with it, but just to recap, when we do imaging, we have, if you imagine that this is a neuroendocrine tumor cell, neuroendocrine tumor cells express somatostatin receptors, and we have tracers that bind to these receptors, and we label them with a radioactive isotope that decays by emitting positrons. There's different flavors, gallium-68 or copper-64 are the radioactive isotope, and dotatate is the compound that binds to the receptor. And then these positron-emitting isotopes decay by emitting photons, and they allow us to take a picture. These days, scans are done as PET-CTs. They have two components, the PET, which stands for positron emission tomography, and the CT, which stands for computed tomography. The PET gives you what we call molecular information, in this case, the expression of somatostatin receptors. The CT gives us anatomical information, where things are, how big they are, how they relate to different organs and tissues in the body. Then we read these images, these fused images. This is a patient with a neuroendocrine tumor with with expression of somatostatin receptors, as you can see with these black dots here. And on the CT, I can tell where these dots are. For example, these dots here are in the liver. Now, these scans are important for staging the disease, for seeing how extensive it is, but the molecular information also is important because it tells us how many of these somatostatin receptors are present on the tumor cells. Neuroendocrine tumors come in different flavors, in different grades. They can be well differentiated. Well-differentiated neuroendocrine tumors have a lot of these receptors on their surface. But neuroendocrine tumors can also be less well-differentiated or poorly differentiated, and then they tend to have fewer of these receptors or almost none of these receptors. And this information can be gained from the scan and determines whether patients are eligible for treatment. So when we do treatment, instead of labeling the compound that binds to the receptor with an isotope that we use for imaging, we can use a different isotope. These isotopes that we use for treatment decay by emitting either electrons, this beta stands for electrons, or alpha particles. And these electrons and alpha particles locally bombard the tumor cells and kill the tumor cells. So first you do the imaging, make sure that there's sufficient expression of somatostatin receptors on the cell surface. If that's the case, then this treatment becomes an option. Now, PRRT was approved by the FDA in 2018 based on multiple studies, the main one being this phase 3 trial, the NETTER-1 trial, I'm sure most of you are familiar with. So since 2018, we've been doing PRRT with lutetium-based dotatate. More recently, the NETTER-2 trial was published, which specifically treated patients with higher grade, well-differentiated neuroendocrine tumors. The response rate was pretty good. About more than 40% of patients showed decrease in the size of the tumors. And the other difference to the NETTER-1 trial was that in this setting here, the PRRT was used as a first-line treatment. So again, it works and is effective and may become an option as a first-line treatment once the approval process is completed and insurances will pay for PRRT as a first-line treatment. Now, what is alpha? So I don't know how many physics majors are here. I hope none, because I'm not a physics major. So, but basically, you have isotopes such as lutetium-177 and yttrium-90. Again, a connection to Sweden. Yttrium is a town, Ytterby, I think, in Sweden where this was discovered. Anyway, yttrium has fallen out of favor because of the side effect profile, but both these isotopes decay by emitting electrons. Electrons are tiny little particles, and then when they bombard the tumor cells, they cause what we call single-strand breaks in the DNA. Alpha particles have about 7,000 times the mass of an electron, so they're really big particles, and they can cause double-strand breaks in the DNA. But if you break both strands of the DNA, the lethal effect on the cancer cell is much greater than just a single strand. So overall, estimate is that it's about 400 times more damaging than the electron. Now, there are different alpha emitters out there. They all have their own advantages and disadvantages in terms of chemistry, the way they decay, how many alpha particles they produce, what their half-life is, and then they also, in terms of how much of that isotope you can get. One thing that's might be a problem, it's not yet clear, but the energy that is released when this isotope decays by emitting that alpha particle is very high. It's about 1,000 times the energy that this binding here has. So by this decay of the alpha particle, the bond between the radioactive isotope and the compound that binds to the somatostatin receptor is broken. So what you end up, you have free-floating isotopes, and we don't really know where they're going. Some of them might have potential side effects by going to the kidney or other parts of the body. And then, oops, sorry. So from all the alpha-emitting isotopes that are out there, none have so far demonstrated any significant superiority compared to the others. Most of the research that's been done is with actinium-225, bismuth-213, and lead-212, which itself is actually not an alpha emitter, but it decays to different isotopes that then are alpha emitters. Now, what's the salient question is how good are alpha, is alpha with a PRRT with alpha emitting isotopes? To date, there are very few published studies. All of them have very small numbers. They all have significant variations in the dosing that they're using, the isotopes that they're using. Most of them are what we call retrospective data, so they treated the patients and then looked back at all the patients that have been treated and to see how well they have done. There's very little long-term follow-up data. There has never been any direct comparison between standard PRRT with electron-emitting isotopes versus alpha-emitting isotopes. In terms of results, some of the published results, this is from a group that used lead-212. The initial phase 1 trial had 20 patients. They were trying to find the right dose as part of this trial. That's what a phase 1 trial is about. These patients had no prior PRRT, and those 10 of these patients that received the highest dose had a radiologic response, meaning you could see that the disease was getting smaller on imaging. The response rate was 80%. This trial has been expanded to a phase 2/3 trial, and they published some data at the recent ASCO meeting where they reported on 36 patients, and the response rate there was then 47%. They also included other patients that had prior PRRT in this trial, but that data hasn't been published yet. Another trial from this group here, this was kind of a hybrid trial. It wasn't really prospective, it wasn't really retrospective. They used actinium-225 every 8 weeks. These patients also received capecitabine at the same time. And about 32 patients received 1 to 3 cycles, 59 patients received 4 to 10 cycles. Tumor response for those patients that it was available in form of RECIST assessment. RECIST is a standard way of measuring things on a CT scan in terms of size. So those patients that had prior PRRT with lutetium-177 had pretty good response rate. 25 of the 53 patients had a response, and an additional 16 patients had stable disease. And those patients that had no prior PRRT, again, pretty good response with 15 of 26 patients showing decrease in the size of their disease. And then this is an ongoing trial here. The people from the Action 1 trial are actually here. They have published data on their phase 1 part of the trial, and they reported a response rate of 29%. So about a third of these 17 patients, the disease got smaller, stable disease in 47%, and unfortunately progression of disease in about 18%. This is now a phase 3 trial, international, ongoing. So far 105 patients have been randomized, and we'll see what this pans out to yield in terms of results. What about side effects from alpha therapy? Again, very little published data, but overall similar to conventional PRRT, conventional meaning with lutetium-177. The main side effect is hematological, so you get some degree of compromise of your bone marrow, so your blood counts decrease, and then usually it's mild, and blood counts recover in between treatments before we give you the next cycle. Some things that seem to be more particular or specific for alpha is alopecia, which is hair loss. It's reversible, but it's much more significant than with the lutetium PRRT. And then recently reported also at the ASCO meeting this year by Dr. Strasberg is something called achalasia, which is a failure of the lower part of the esophagus to open up and to let the food into the stomach. Can be pretty painful. They said they were able to treat it endoscopically by injecting a sort of a muscle relaxant, but an interesting side effect that nobody yet has really an explanation for. And then, as I mentioned earlier, because of the isotopes decay and the falling off of the radioactive isotope from the compound that binds to the actual receptor, the resulting free-floating isotopes, and some of them going to the kidney, there is some concern for renal toxicity. Where can you get alpha PRRT? Well, so far it's only available on a trial basis. This trial here has actually closed now for accrual, and they're following the patients, evaluating the data, so hopefully there'll be a publication soon. This is the Raised Bio trial. It's ongoing. We at UCLA are part of it. We have enrolled 1 patient so far. He's actually here, and he's doing very well. Glad to report. This is another trial here, being offered, I think, in Florida, Iowa, and Illinois. They're using the lead compound, estimated completion 2029. So is alpha right for me, or you, I should say? So as I said, it's only available as a clinical trial. We'll have to wait on the outcome of the trials to find out how good it is and whether it will become an additional line of therapy in the future. So at this time, the tried and proven therapies, and there are quite a few of them, should be applied first before you go for something experimental. Oops. So that's what I have to say. I should add that there's other research going on with what we're right now using, at least in nuclear medicine for treatment, are what's called agonists that bind to the somatostatin receptor. There are trials going on or being started with antagonists that have more binding to the receptor or better binding to the receptors, also labeled with various radioactive isotopes. There is another beta-emitting isotope that has additional electrons called terbium that's being evaluated. So there is ongoing research. Unfortunately, these things take time, and we really have to wait for the data before we can recommend something or approve something. Thank you very much.